So to begin with, and this is good because this is the proportion of the patients you would expect to have any one of these symptoms and what they need to meet the criteria. So they need to have migraines for at least some of them are more than 4 hours. There aren't many that are less than 4 hours that I've my experience. If someone has a headache for 1 hour, unless they take something we call an abortive medication that stops them, like Imitrex, then they would normally, their natural course should be more than 4 hours, sometimes up to days. And they have to have 2 of the 4 next criteria. Now, 3 is pretty much a no-brainer. Nobody's coming in for migraine headaches that are mild. So you can pretty much assume everyone's got a moderate to severe intensity. You almost always expect 1 or 2. But I think a fair portion of people I've seen have been bilateral. So maybe half is about right. The throbbing or pounding is, I've seen maybe 1 or 2 who describe them as steady and not pounding, or pulsating, like you can hear your heart beating in your ear, for example. But the vast majority will have some degree of that. And even if they say some of them are like that, that's fine. They don't have to say everyone is like that. Aggravated by movement, in someone who has a migraine and it doesn't limit their activities, meaning they're around cleaning their house and doing, working out in the yard and things, would probably be suspicious that that was migraine. The normal story, what's the normal story of what someone does when they have a migraine?
Lie down, close door, lights off.
Yeah. So that's much more typical. And, I've had people who've had to tough it out through the day, but they're certainly not, interested in doing a whole lot of activity during that time. And the D then criteria, you have to have 1 of the following. Again, light sensitivity, 81%. I've occasionally had somebody who didn't have, I remember one guy where all we could get was nausea, but it's almost universal that people have light sensitivity, sound sensitivity. Sometimes they'll have smell sensitivity. Those are the ones who really get nauseous because they feel smelling something makes them nauseous. And sometimes they have, I can't remember what the name for it is, just this touch sensitivity, like anything touching them, their skin will be like amplified and feel painful. And then just not the result of another disorder, really. Yeah, I think what that comes into play is when you talk about being concerned about, menstrual-related migraines. There's not really a reason to exclude someone whose migraines are primarily around their menstrual period. It's not a separate disorder, menstrual migraines versus other kinds of migraines. The majority don't have auras, and an aura is almost always something in your visual field. More often than not, it'll be described as spots, sometimes wavy lines, sometimes lights, but it's virtually always something in your visual that you're seeing. Other feelings like I just feel something, I don't usually count as an aura. Okay, so cluster and what's different. There are a lot of people who say they have cluster headaches who don't have cluster headaches. The cluster means they come in clusters, meaning you'll have a week or 2 weeks or a month when they'll just be horrible and then they'll just go away. And then, 6 months, 3 months, a year later, they'll come back. So people think of them, and this is kind of the way they can be. So people think if I have a series of headaches and then they come back over another time, that they're cluster headaches. But it's more than just that they're separated in time. It's actually some very specific symptoms that when you hear them, you'll see they're very different from a migraine. First off, these are always unilateral, always around the eye, and it feels like an ice pick right, sticking in right up there. Sometimes it's described as stabbing or burning, but it's a very steady, sharp, really almost excruciatingly painful. And they get a lot of symptoms around the eye. Their eyes will water, or they'll get congestion, they get swelling, they may get flushed or hot, which is obviously none of those things are things you see with migraines. So you can start just asking what those other symptoms are. But anything where someone has a one-sided, very steady stabbing pain, not stabbing like a pulsating stabbing, but just like someone just stabbed you with something, then you start thinking about cluster headaches. The other thing is they don't last usually more than 3 hours, so right away you're differentiating them from a regular migraine. Now it's obviously there's complications. You can have a cluster migraine and then it follow with a tension headache, but that the key parts of it shouldn't last more than 3 hours. You can get many a day, and so you can have daily, you can have many a day. They can most come in clusters, but there are people who don't even have that luck. They'll have them. They're just absolutely tortured. They just always have them. And they have this strange quality, frequently we call metronomic, meaning they occur at, they may wake you up at 3 every morning or every noon, but they have a very sort of circadian rhythm to them. And that's another piece of the differential. A sinus headache obviously is here, which can certainly feel like tension headaches are here. Sinus headaches, often when we differentiate them, is if you push on there, they should hurt because of the buildup of mucus in the sinus areas, which means there's sensitivity. So if there was pushing on there and it doesn't hurt, I'd probably call it a forehead headache more than they just call it sinus because it's here, or maybe they've had a history of sinus problems. Tension headaches they can seem all sorts of different things in all sorts of different parts of your head. The classic person who has tension headaches is someone who has a chronic level of tension in their neck and shoulders. If they go to the massage therapist, the massage therapist will comment on how tight their shoulders are. Even if they're not necessarily aware of it, they have a really high level of tension, which is why they almost always, most of them will start back in this part of the head. They may even describe the neck with the back of their head. Not all of them, but that's a very common presentation. So that the pain is not pulsating, it's steady. People feel like pressure is a common way of people describing it, that there's like something is putting pressure or putting my head in a vice or something where you feel like it's a tight feeling in your head. And it's not typically have the light sensitivity, the sound sensitivity. It doesn't have any auras or warnings. So you can see it's pretty different than a migraine headache would be. And it can be anywhere in your head. It's not usually unilateral, it's almost always bilateral. Sometimes, though, you'll get people who have headaches that are unilateral because they have some sort of neck problem. Often we can just get those by, postural problems, craning our neck, in a certain position, begin at your computer, and then you'll get problems where they'll be more on one side, and those are all most often due to some problem you're having in your neck. But otherwise, a lot of them, people just say everywhere in my head or on the top of my head or the front. It's a classic picture of someone going like this, because they're rubbing their temples because there's so much muscle tension going on in there. A real common, all headaches actually, not just tension headaches, being deprived of sleep, water, or food are three of the most common. So being sleep deprived, getting dehydrated. If you ask, you see this a lot in teenagers or everybody, but in Florida, people going out and gardening and then coming in with a headache of whatever type because they've gotten dehydrated, or not eating, or obviously being sleep deprived. All of those are very common triggers. When you ask people with migraines, at least when I do, very few of them have any clue as to what brings them on. The most common, the thing they say is stress, which might make some sense when we talk a little bit about CGRP, but that's really the limit of it. There are a lot of actual triggers in foods and dyes, and if people, there's actually a list, and I'm going to bring it with me, of food and dye and thing triggers that are common and to cause them, and I usually would recommend to someone to sort of look in your diet, make sure, read all the packages, see what dyes are in what. It's an amazing number of things there are dyes in. And you can sometimes eliminate them just by eliminating certain things from their diet. And as I said, they're often go along with people with depression or anxiety, and particularly generalized anxiety. It's one of the criteria, actually, where you get headaches, that sort of muscle tension headache. I said 20% of people have tension headaches, although I suspect it's higher. I think at some point everybody gets a tension headache once in a while. Okay, so what is CGRP? So what causes a migraine, and why does it hurt so much? So it's a little, we call it peptide. Peptide means a set of amino acids. There are a lot of, so it's like not big enough to be a protein. And there are a lot of things like growth hormone, a lot of things that are just small like that. In fact, I put the most common neurotransmitter. I said it's the most common peptide. And there are a lot of different peptides that are neurotransmitters. So it's basically all the way through the nervous system. It's mostly, the parts of your brain, your brain itself can't feel pain. So where you're feeling the pain from are the arteries that are running like in the, outside of the brain. And there are receptors for this neurotransmitter, both on the blood vessels and on the nerve cells. So it has the effect of both causing veins to dilate, and whenever you're having a migraine, some fundamental part of it is your veins are dilating, which is why caffeine, which has a constricting effect, is used so often to treat them. So anything that helps migraines, and some usually has some constricting effect on the blood vessels just to reduce the flow. Now, how that relates to pain, and why that should relate to pain, I don't know evolutionarily what the connection is, but they're also all over the pain receptors, so that they intensify whatever degree of pain there is. They just sort of intensify it. They cause inflammation. So they're bad. That CGRP is bad. So this just shows you there's CGRP, just like norepinephrine, serotonin, they cross there, and those are smooth muscle cells on the artery. So they'll cause the smooth muscle cells to relax, and that causes them to dilate. Now, one thing I'll just about come to is you see this is 5-HT2 stands for serotonin. And you'll see there's a serotonin receptor on this side, which becomes important when you talk about how all of the triptans work. So what we're doing, there's different things you can do. You could block the CGRP here using a receptor blocker. You could reduce the amount that's being released, or you can take a lot of this out of circulation. We're not working with any ones that are blockers. And usually the reason we're not is because it's hard to get them into where they need to be, get through the medications they haven't been able to get into the CNS, so forth. So, but I'm sure there will be some that are just pill ones that block CNS, and they also don't last as long. or the last thing you can do is by activating that, which reduces the amount that's being released. So those are the three things you can do. So what this shows is that the CGRP, I don't know if you remember the trigeminal nerve, the one that goes like this. You take that anatomy, no? You put your hand up like that and put kind of here in it. It's because there's 3 nerves, and actually I've got 4 fingers, so there's too many, but they run like that. So the pain tends to come from that nerve area. And so CGRP causes the blood vessels, as I said, to expand or to dilate, whereas when you activate these serotonin receptors, which is what triptans do, it does the opposite. It prevents the dilation and prevents these from being released. So it sort of blocks the release of the CGRP. So it turns out we've been doing the triptans, but their really basic function is they stop CGRP. So we're actually more getting to direct effects. And the problem with serotonergic medications, as you know, is they hit all sorts of serotonergic stuff that you don't want them to hit, which is why you get side effects, so many of them. And part of the thing with CGRP, I haven't seen any really significant side effects. I don't know if anybody else has, but you're being so specific for something, so you're not hitting the CGRP systems throughout the body that you're affecting. So what does it have to do with migraines? Well, just we know is that during migraines, the CGRP levels go way up. It's actually increased in other pain disorders. If you take fluid out of the joints of patients with osteoarthritis, you'll see high levels of CGRP in there. So it affects pain in other areas of the body. It'd be interesting to know, you would think that if that was true, that these infusions would affect other pain disorders. And I think maybe that's why they asked, do you have other pain disorders, and is it getting better as well? Because they're curious what else it's going to help with. And when they infuse the CGRP, they can trigger migraines. And when they block the CGRP, then they block them. So it's a very simple, it's one of the simplest sort of ways of systems. Things are usually more complex than this, but this is pretty straightforward. And so what we're doing with our trials so far with CGAG and with TIVA are both doing what we call monoclonal antibodies. Now, monoclonal antibodies were first developed in relation to cancer. So cancer cells would produce a specific type of protein on its surface that was unique just to the cancer cell, that no other cell would produce it. And so they would figure out what that was, and they take that particular, we call antigen or protein, and they stick it in this mixture of spleen cells that are filled with, there's something called beta cells. Those are the ones that make antibodies. They stick it in there, and then the beta cells will churn out antibodies just to this one, that's why it's called monoclonal, just this one protein. And then you could use that in cancer chemotherapy, because when an antibody sticks onto something, it attracts other immune system cells to come in and destroy it. So it's a trigger to destroy this. So the same thing has been done with CGRP, where they basically just put CGRP in this bath of B cells, and they produce all these antibodies, and that's how they produce the monoclonal antibody for CGRP, which then binds. And essentially, you're taking it out of circulation. And I think one reason it probably lasts a long time is because you're actually just taking it out of circulation as opposed to just blocking it and keeping the same amount in, and as soon as you leave the block, it's back again. So most likely this just gets tossed out, and tossed out with all the lymphatic fluid when they do that. I thought I would just end with some interesting things. These are things we can tell people about, things they can do other than medications, not during the trial. These are things they can't do during the trial. But this is good because it goes to levels of evidence in terms of how how good the proof is that this works. And it's fascinating that there's one that's at level A, which means it's maybe as effective as the medication equivalent, which is called Butterbur. So you have friends with migraines, tell them to try that. The combination of feverfew, magnesium, and riboflavin is also very effective. There just haven't been as many trials. And then there's a whole slew of things that have been tried with varying degree of results, and that's what the possibly effective or conflicting data ones are. So there are always a few people who are going to respond, but if you look at this, you say, well, start with Butterbur, and then if that doesn't work, try number 2. And so it's good and nice to have some options, because obviously nobody wants to be taking medications. And so my thought is, after this trial, what do I tell people about what to do about their migraines? And I would start them on one of the prophylactic ones if they didn't, but I'd probably also recommend they do one of these, as well as go through things in their diet that may be, give them a list of all the things in their diet that may be triggering, because you want to just eliminate everything possible that could be contributing to them.